Good afternoon to you all. At the outset, let me thank Dr. Ashish for his kind invitation. My brief today is to speak on total hip replacement in the protrusio scenario. We all know the definition of protrusio. By and large, it was described as early as 1824 by William Otto, and then subsequently again by Gurrit in 1854. Now, when we look at protrusio, we know that there are basically just that one component wherein there is proximal migration and medial migration of the femoral head beyond the Kohler's line, which is the ilioischial line. So we want to know whether it is primary or whether it is secondary to some kind of any other cause. So the primary, of course, may be characterized by progressive protrusion, and usually in middle-aged women, may be associated with osteoarthritis and could be familial. Secondary, of course, there are numerous causes. The list is exhaustive, but common causes which we need to rule out remain rheumatoid, osteomalacia, Paget's, and of course, renal osteodystrophy. Now, when we look at the radiographic picture, we know that there is an increased CE angle. Anything more than 40 degrees tells us that there is an element of protrusio already present. Of course, whenever we are looking at a situation where there is a bilateral case, it needs to be worked up thoroughly before we brand it as a primary. So, inflammatory arthritis, Paget's, osteomalacia, as well as renal osteodystrophy need to be exhaustively investigated and ruled out. In unilateral cases, the ballgame is slightly different. There could be associated trauma, which is a central fracture dislocation pattern with various kinds of things, along with failed hemiarthroplasty. We commonly see this in post-AMP scenarios where the patient has been walking on it for a very long time and gradually the acetabulum tends to erode. Failed total hip replacements, again, can present in a similar manner. Tuberculous arthritis and, of course, fibrous dysplasia, to name a few. Now, when we are looking at protrusio, we also need to differentiate another entity, which is coxa profunda. So when we are looking at the radiological lines, in a case of a protrusio, both the medial acetabular wall and the femoral head, they tend to project medial to the ilioischial line. However, in a coxa profunda, the medial acetabular wall projects medial to the ilioischial line and the femoral head remains lateral. Now, why is this important is during our surgical intervention, the recommendation is to aim for a coxa profunda kind of a picture rather than to go for a more lateralized picture. Now, Dr. Ranawat in his paper initially mentioned about the center of rotation. So we need to template it. And the templating will effectively tell us what is the degree of medial defect, and that exactly will tell us how much of a medial graft is needed to fill up that particular defect so as not to over-medialize or to over-lateralize. So a CT scan and a 3D recon usually is a must to assess for two things. First and foremost, the integrity of the medial wall and, of course, to look for any column defects. Now, the significance remains that there are several papers which I'm quoting from wherein the head rotation center in the anatomical location is preferred. The medialization tends to impair the medial support of the acetabulum, and therefore early cup loosening and wear is known. Lateralization tends to increase the stresses across the femoral component, and thereby failures occur in that end. Again, the superior displacement of anything more than 5 millimeters tends to change the load distribution across the acetabulum. So these are things to be borne in mind when we are trying to recreate the center of rotation. Now, the classification, we all quite familiar with it. There is a class 1, 2, 3, which is described by Chandley. Now, the classification may be good as far as just a documentation or an academic study is concerned. However, does it really help us when we are thinking in terms of planning a surgery? So what I would try to do is trying to tell you regarding what is it that the patterns we need to recognize before we go in. So we need to assess three important things before we get in. One is, what is the status of the medial wall? Second, is it a convergent type of a defect or is it a divergent type of a protrusio? And is it a simple protrusio or is it complex with some amount of migration? Now, from a difficulty point, as far as the surgical concerns are concerned, what does a good medial wall tell us? It tells us that it is basically something which has been brewing over a period of time such that the bone has got a chance to remodel. And thereby, these, despite the fact that they look quite ghastly, are something which are structurally quite sound. And this, in turn, will tell us that we can go ahead with some form of impaction grafting without any fear of breaching the medial wall. However, if you're looking at a status where there is a defective medial wall, that's not something which we can think of doing. So when we are thinking in terms of a convergent protrusio, grafting is required. However, in case of a divergent protrusio, you can accept a high hip center, and impaction grafting is what is recommended. Now, when a divergent defect is seen, when we tend to ream, the defect becomes larger and larger, and it tends to toggle within the cavity itself and leaves us feeling absolutely not really confident with regards to the cup capture. Because at the end of the day, we want a rim capture to get our cup stable. However, in case of a convergent defect, as we ream, the defect tends to be smaller, and we can probably get away with a primary cup. Now, when we're looking at a convergent, grafting is done. However, it's not critical, though, as I did mention earlier, the center of rotation, if we can recreate the amount of defect which needs to be filled in, that is optimal. Reaming may suffice, and of course, reverse reaming can be done. However, in cases of a divergent protrusio scenario, particulate graft matter is what is the recommended thing, and no reverse reaming is recommended, and the ideal method is to actually impact it into the wall. In these cases, a highly porous cup like a gription or a tantalum would be preferred to maximize the host-bone interface. Then we come to the point of whether there's only medial migration or is there medial migration and proximal involved. How more often than not, when we are looking at there is medial and proximal migration, there is almost always anterior column bone loss. So this needs to be borne in mind, because this is where your cup rim capture is affected. And if we are overzealous in terms of trying to do something, more often than not, we'll land up in an issue which we can't correct. Now, protrusio hip exposure is again always a challenge. So the attempt to be dislocating the hip should always be done. Subluxation, of course, bilateral traction by your assistant is always invariable. All marginal osteophytes must be removed. And of course, a complete capsulotomy is mandatory. Very rarely, a Gans flip osteotomy can be done if in case we are really struggling to get the hip out. Now, the initial urge is always to try to do an in situ osteotomy, which must be resisted, because any attempts to initially gently try to mobilize the hip does tend to free up the soft tissue a bit and does help in movements. So we've all seen X-rays where they look fantastic, but the movement really doesn't really concur with what's there. If it's not possible to dislocate, certainly an in situ osteotomy, wherein you remove a thin wafer of bone, like a biscuit, is to be done. Trochanteric osteotomies, and in case if we are doing a revision scenario, an ETO in a well-fixed component is almost always necessary. The indications of an ETO remain revision of a well-fixed stem, especially a cemented component, or a broken stem, or a long cemented stem or plug. Now, when we're looking at these things, we also need to look at whether there is proximal migration and if it's a divergent defect. This is a bottleneck kind of a defect, and these frequently make it technically more difficult. Now, how much of graft to put and how much of medialization? This is almost always the question which plagues all of us. Now, this is an example of an unacceptable medialization, and the second is an example of an unacceptable lateralization. Now, the problem is these patients have been walking with a low offset for a very long time. So if you do tend to lateralize them too much, they don't remain very happy. So the concept of judicious lateralization is what needs to be excised. So bringing it out to the anatomic mouth is desirable, because these individuals are used to walking with a low offset and tend to be happier. However, restoring bone stock medially is of paramount importance. Now, the principles in management of complex protrusio, if it's a simple protrusio, particulate bone graft, dome screws to lateralize the cup should be enough. However, if it is a protrusio with proximal migration, particulate graft with dome screws, except a high hip center, wherever you find good bone and a highly porous cup should do. However, one must be prepared to think in terms of an APC, which is an anti-protrusio cage, as and when indicated. So the algorithm when there is a proximal migration present is, if medial migration is more than the proximal, impaction grafting at an anatomical hip center. If proximal migration is more than medial migration, no grafting and a high hip center can be accepted. Of course, in conditions where there is proximal migration with a poor medial wall, we have no choice but to think in terms of an anti-protrusio cage. So this is just a case, 61-year-old lady, known case of rheumatoid arthritis, a household ambulator. This is the CT scan, which shows that the medial wall was intact. So we went ahead, we did a minimal amount of grafting, and this is the result. We went ahead for a hybrid. We did a cemented stem on an uncemented cup. So to conclude, the management of protrusio with an uncemented cup is predictable with excellent results. The principles are critical to ensure a good outcome. So the few things to be avoided are limb length discrepancies, impingement, low neck resection, and an enhanced horizontal offset. The algorithm is useful to plan and execute surgery in protrusio. I thank you all for your kind attention.
Thank you, Dr. Prabhakar.
Thank you.
And now, any question from the audience? No question. So our next speaker is...
My question to Dr. Prabhakar, excuse me, sir.
Sir, of course.
Most of the potential cases, the femoral head is present and you are just using for the graft. But in case where the potential is due to the failed bipolar, in which case, what is your protocol to fill that defect,
Sir,
and
where
from you take the graft and all these things?
So we have access to a bone bank. So if in case I'm facing a scenario wherein I anticipate that I will need to probably do an impaction grafting, I tend to take the help of a bone bank. Other than that, you can take something from the iliac crest. Autologous bone grafting is an option.
Or use potential case or all these things in this case?
Yes, of course. As I did mention, if I feel that the medial wall is deficient in any way and I'm not able to do a proper impaction grafting, I would keep the cage anyways as my backup. If I can get away with putting a mesh and perhaps impacting it such that there is no major defect as far as the medial wall is concerned, I can probably get away. But protrusio cage has to be at the backup at all times.
Thank you. Thank you very much.
So our next speaker is
Thank you,
Dr.
sir.
Khemani. He will be talking on